When it comes to treating endometriosis, women have several options, and we'll look at each through a few lenses. Primarily, how effective is the option at treating infertility and at treating pain?
We'll delve into surgery, IVF, IUI, and medication. But to summarize, this is how it looks.
Surgery can be helpful at treating infertility, more often for patients with stage 3 or 4 endometriosis. Surgery is also the most effective at alleviating pain, but it's invasive and carries risk, especially if surgery is done to remove endometriosis on the ovary.
Next, IVF is easily the most effective option for treating infertility, but it does little to alleviate pain symptoms. It's costly and rarely covered by insurance, but many of its risks can be contained.
Next, IUI, or intrauterine insemination, is only somewhat effective at treating infertility and does nothing to deal with the pain. After 3 to 4 failed IUIs, it probably makes sense to stop, even though IUI is comparatively inexpensive and generally non-invasive.
Finally, taking a medication to suppress a woman's ovaries only improves fertility in conjunction with IVF, but it does reduce pain for a period of time. That said, the risks can add up, especially if it's taken for more than 6 months.
As we dive into treatment, we'll occasionally refer to how effective a treatment is in treating patients with a certain stage of endometriosis.
The stages are 1 through 4, which indicates how widespread the endometriosis is. Stages 1 and 2 are mild to moderate, while 3 and 4 are moderate to severe. The stages actually have nothing to do with how severe a woman's symptoms are or how likely she is to conceive.
These stages are useful in determining which type of patient should get which type of treatment. But staging is also very subjective. Doctors disagree all the time on what stage a patient is, and as we said before, there's little correlation between stage and a woman's ability to conceive.
During surgery, a doctor can try to remove or destroy the endometriosis. When it comes to treating pain, over 60% of patients have pain relief compared to those who don't have surgery. But unfortunately, about half of those patients will have their pain return.
And as for improving fertility, this is what typically happens. A woman will have surgery and then try to conceive naturally for a few years. Now, how often does that work?
For patients with stage 1 or 2 endometriosis, surgery is really inefficient.
So for every 12 women who get surgery, only 1 woman will deliver a baby beyond what would be expected if these 12 women skip surgery and just tried to conceive naturally.
For women with stage 3 or 4 endometriosis, surgery does yield some better results. 2 or 3 years after surgery, about half of women will have conceived naturally.
How does that stack up to the alternatives? IVF gets pretty similar results, but does it in a matter of months and not years, as is customary with surgery. And surgery certainly gets better results than doing IUI or having no treatment done at all.
One especially useful tool for estimating a woman's ability to conceive after surgery is called the Endometrial Fertility Index.
With a few inputs, the EFI can predict a woman's odds of conceiving within 3 years after surgery. Check out the written portion of this course where you can see all the details.
Why is EFI valuable? Well, because if a woman opts for surgery and then waits years trying to conceive naturally, if her odds of success are low to start with, she'll actually lose critical time that could have been devoted to IVF.
As you can see, IVF success rates decline with age, and so waiting years can cut success rates dramatically and possibly relegate IVF to being totally ineffective if it's needed.
Again, here's former ASRM president David Adamson, who actually developed the Endometrial Fertility Index.
It can be a difficult decision whether to have surgery or whether to do IVF to have a baby. But some of the things about surgery are that in order for surgery to be successful, the woman has to have at least 9 months, if not 15 months or so after the surgery in order to try to get pregnant. In other words, it takes time to get pregnant after surgery. If the woman is older, you may not want to give up 9 to 15 months of time after the surgery. It's not that she doesn't have it, but as you use that time up, her ovarian reserve and egg quality is going down, so that you're actually losing more than you're gaining. The other thing is that you have to have reasonably normal sperm if a woman's going to get pregnant on her own, or even with ovarian stimulation and IUI. So if the sperm have a problem, then surgery is not going to be a good idea. You could get a beautiful job fixing endometriosis, but if the sperm don't work, it's not going to help you get pregnant. So in that case, you wouldn't want to do surgery either. And sometimes surgery would be indicated if there are other problems, possibly fibroids, which is a complicated issue, or if the woman has adhesions or other problems that are causing pain that you know about, then it could be worthwhile doing laparoscopy. But in terms of pregnancy itself, you want a woman who's somewhat younger, has 9 to 15 months, and does not have other fertility factors. So if she's getting older, has other fertility factors, or doesn't have a lot of time, you're going to want to go to IVF and not do the surgery.
And now for the risks of surgery.
First and foremost, if a woman has endometriosis on her ovaries, by removing the endometriosis, there's a risk that her ovary and egg supply will get damaged. That's a real problem if she wants to conceive, especially if she's older or already has a low egg supply.
We have to be the most gentle as possible, because this cyst has been grown in the ovarian cortex, surrounded by primordial follicles. If we do not remove carefully and we do not dissect out the capsule of the cyst, we may risk to remove also part of the cortex and then the ovarian reserve of the patient.
But the second issue is that when you take it out, you can cause some damage to the ovary, because you can't take unhealthy tissue, the endometrioma, out without having the interface where it is up against the normal tissue.
So why not just leave the endometriosis on the ovary? Well, leaving it in place probably also interferes with fertility.
The whole issue of endometriomas or ovarian cysts that are started from endometriosis in the ovary is very complicated. And I think that if a woman is going to be trying to get pregnant on her own, there's pretty reasonable data that the endometrioma probably is reducing her pregnancy rate. And that's because it distorts the ovary, alters the blood supply, it's an inflammatory environment, which is not good for the eggs, et cetera.
Not to mention that an endometrioma, that's what an endometrial cyst on the ovary is called, can grow and rupture. Or maybe even worse, it's not a cyst at all. It's actually cancer. So there's definitely an argument for taking out what looks like an endometrioma.
So a reason to take it out is that it's a problem now, and it could be a bigger problem in the future, and it can cause pain, and it can rupture, and it can be a problem.
The main reason to remove the endometrioma is to avoid that the endometrioma will grow and somehow will just explode himself and will cause complications as a peritonitis.
Okay, so removing an endometrioma is bad, and just leaving it there can be bad too. So how do experts think through the risk-reward calculation of when to take it out or leave it? Often it has to do with the size of the endometrioma.
An endometrioma is not a good thing, no matter how you look at it in terms of trying to get pregnant. But that's a different question from should you remove it, before you do IVF, or how big does it need to be? Now, an endometrioma by definition is 1 centimeter across, which is not that big. And most of us these days would not do surgery on a 1 centimeter or 2 centimeter endometrioma. If you're not pregnant after 3 or 4 months and you have a small endometrioma, you're saying, well, now we're going to do IVF. Now we're going to go to IVF. At that point, the question is very different. The question then becomes, if you remove the endometrioma, will you make the IVF pregnancy rates better? But what most of us do is that if the endometrioma is under 3 or 4 centimeters, I'd say even 4 centimeters, we generally do not treat it. We leave it alone and go to IVF.
There is a big amount of literature showing that removing small endometriomas is really causing more harm than good, because you are even decreasing the ovarian response, the ovarian reserve of this patient.
If it's 4 or 5 centimeters or more, we generally treat it. The reason endometriomas at 4 or 5 centimeters are treated is that, 1, the woman often has pain and difficulty with it. 2, there are some risks at IVF that you may get into the endometrioma, which can result in infection or problems. 3, we do believe that the endometrioma may reduce the response to ovarian stimulation, so you get fewer eggs if you do IVF. And 4, there is some risk, it's small, but that cyst is not an endometrioma. It could be a different kind of cyst and even rarely a cancer. So once it's about 5 centimeters, almost all gynecologists are going to say, we better go take that out so we can get the tissue out of there and do a biopsy. The pathologist make sure it's only an endometrioma. Now, back to the whole issue of the concerns over this, we know, one, the endometrioma is going to be reducing fertility, it's going to be damaging the ovary, and the endometriomas, we think, can get bigger and make more damage in the future.
But even if the endometrioma is large, it still gives doctors cause for concern. They know removing the endometrioma will also involve removing some healthy ovarian tissue. If a woman already has low ovarian reserve or she's older, this may impact the odds that IVF will work for her if she needs it.
There's no question there's real risk. And if a woman has had an operation on the ovary before, or if she's a lot older, or if she has low ovarian reserve, low antral follicle count, you have to be especially careful before operating, and your burden to operate goes up. In other words, you have to have better reasons to operate on the woman.
So once endometriosis has been removed from the ovaries, a woman's ovarian reserve diminishes. Here are 3 studies that show such a decline as reflected by the drop in AMH.
And for women who already have a low reserve, this kind of surgery can actually push them into menopause. Obviously, that's a huge problem if they're hoping to have more children.
If you have a low ovarian reserve and are contemplating surgery to remove endometriosis on your ovaries, and you may want more children, you should strongly consider freezing your eggs first.
Freezing eggs in and of itself requires real forethought and planning. So we actually have a whole course to prepare you.
If a patient that is going to have surgery for endometriomas should preserve their fertility, this is a very wise decision to take. But again, it should be taken according to the personalization situation. If the patient has a very poor ovarian reserve and a big endometriosis cyst, I will suggest to do this to preserve whatever she has now before the surgery is done. If, on the other hand, she has a good ovarian reserve with 8-10 follicles and a big cyst to remove, it's not necessary to preserve fertility, to freeze the oocytes prior to the surgery.
A last note on endometriosis surgery: the procedure is a delicate one, and more experienced surgeons record complication rates that are nearly 50% lower than less experienced surgeons.
Now, on to IVF. While IVF does nothing to mitigate the pain of endometriosis, it's by far the fastest route to pregnancy. That's true for women with stage 1 or 2 endometriosis.
And it's also true for women with stage 3 or 4 endometriosis, getting comparable results to surgery in a matter of months rather than years.
And incremental IVF cycles tend to increase the odds that a woman will conceive. As you can see for other fertility treatments like IUI, that's not the case.
Furthermore, if embryos are transferred one at a time, the risk of a multiple gestation delivery can be brought down to 1%. Finally, in 20% of cycles, enough embryos are created to allow families to have multiple children from a single retrieval.
The major negatives of IVF? Well, first, it costs upwards of $20,000 per cycle. And unlike with surgery, nearly all patients are forced to pay for it out of pocket.
And when we compare IVF to IUI, which we'll do more thoroughly in a second, IVF costs 5 to 40 times more, but it's only 3 to 5 times more effective. So you could say the costs rise faster than the rates of efficacy. Lastly, IVF is far more invasive than IUI is.
But if your focus is to get pregnant as soon as possible, there's simply no substitute for IVF. Case closed.
If a woman has endometriosis and undergoes IVF, there's good reason she should go on Lupron to temporarily suppress her ovaries, either before the start of the cycle or between the egg retrieval and the transfer.
Why? Because the ovaries produce estrogen, and as you might recall, Endometriosis feeds off of estrogen, so shut down the ovaries temporarily, reduce estrogen production, and maybe this helps starve endometriosis and improve outcomes.
We start the ovarian stimulation about 3 months before we're going to start the stimulation. So the woman has the leuprolide acetate, which she takes, and then we roll straight from that into the ovarian stimulation drugs and then into the egg retrieval, and after that, the transfer, which very commonly these days is a frozen embryo transfer later, but not always.
And as for drug protocols, no protocol has really distinguished itself as being the best one for endometriosis patients.
When it comes to fertilization technique, there is some data suggesting that using ICSI drives better rates of success, but that data is far from ironclad.
As for the decision of whether to transfer embryos immediately or freeze them and transfer later, there's high-quality data that shows that freezing and transferring later drives better outcomes for endometriosis patients. But again, there's some disagreement on that.
Why might freezing embryos and waiting a month or more after the retrieval help? Well, right after a retrieval, estrogen levels are high. Remember, endometriosis feeds off of estrogen. Waiting to transfer allows enough time for estrogen levels to fall back to earth and maybe reduces the inflammatory effect of endometriosis in the uterus.
If a woman chooses to freeze her embryos and delay transfer, there's good data that shows that putting her on ovarian suppression between retrieval and transfer is really useful. Why is that not a problem to suppress a woman's ovaries at this point? That's because you've already retrieved the eggs from her ovaries.
And you're no longer focused on the ovaries. Now, all you care about is the uterus, and if shutting down the ovaries to discontinue estrogen helps keep endometriosis under control, then that might improve the uterine environment and make it more hospitable for an embryo to implant.
Finally, if a woman has a hydrosalpinx, having that repaired after retrieval but before transfer drives far better outcomes, as you can see in these 3 different studies.
IUI, or intrauterine insemination, does nothing to alleviate pain. And when it comes to fertility, it barely gets double-digit success rates per cycle. As a result, it trails surgery and IVF by a long shot and is only marginally better than doing nothing.
And as you can see, stringing together a lot of IUIs month after month generally yields pretty disappointing results.
And when IUI does work, it carries a higher risk of multiple gestation pregnancies, which in and of itself can be dangerous to mother and children. So why on earth would anyone do IUI instead of IVF?
Well, because IUI is cheap compared to IVF. It works about 1/3 as often, but costs 5 to 40 times less. So some argue it's really good value.
Maybe so, but don't forget, if IUI doesn't work after a few cycles, it probably won't ever work. So no matter how cheap IUI is compared to IVF, if that next IUI cycle is almost guaranteed to fail, then that's just money down the drain.
Okay, so ovaries produce estrogen, and estrogen feeds endometriosis. What about just taking medication to suppress the ovaries? Does that accomplish anything?
Well, sort of. For one, it does improve menstrual pain. But after 6 months, women need to discontinue treatment, and for many, the effect wears off.
Now, what about for fertility? These drugs temporarily shut down a woman's ovaries so she can't conceive while on them. So does that make them useless from a fertility perspective?
Actually, no. These drugs, when they're used in combination with IVF, have a real role to play, either taken before a cycle starts or between the retrieval and transfer if a woman elects to freeze all her embryos and delay a transfer.
Using medications like Lupron do have some drawbacks if taken for too long. Oral contraception or a progesterone IUD are also acceptable alternatives.